I was asked by the residents and some of the fellows to talk about electrolyte disorders. Just to recap what we did so far in the last several weeks, we talked about acute kidney injury, and I think that was about 3 weeks ago or more. And then we covered that area, and then we moved on and we covered chronic kidney disease, and the separation we said is 3 months between acute and chronic. And then after that, I think in that same talk, I extended that talk and I made it cover kidney replacement therapies, all the available renal replacement therapies. And that included all forms of dialysis as well as kidney transplantation. And so now I was asked to cover the areas of electrolyte imbalance. And there are 4 talks actually here. So when you talk about electrolyte imbalance in clinical practice, really 80 to 90% of that, actually even more than 90%, is basically disorders of sodium and potassium, because these are the most common disorders we see in everyday clinical practice in the hospitals. Of course, there are some other disorders. If you want me to focus on those in a separate talk, I'll be happy to. And those are the divalent elements. That's the calcium, the magnesium, the phosphorus, and that way we cover everything. But right now I'm focusing on disorders of potassium tonight. I will talk about everything related to potassium, both disorders, hypokalemia, hyperkalemia, and I'll talk about the physiology, very important, the basic physiology of potassium handling by the kidney and by the body as a whole. And then after that, I have a bigger talk on sodium and water. When you talk about sodium, you have to talk about water. It's actually, don't talk about sodium. It's basically a talk about water, water metabolism and water disorders. So that will be the next talk, inshallah, before Ramadan. There's only 2 weeks to Ramadan, I think now, or just over 2 weeks. But tonight, the focus is on potassium disorders, what we call dyskalemias. And I will explain these words in the next few slides. We call it the killer K. Of course, the atomic number or the atomic symbol for potassium is K, and it is a killer electrolyte. It causes a lot of mortality and morbidity in clinical practice. So where did the name came from? Why do we, I mean, we know potassium, that's the English word, potassium. And then there is kalium. Potassium is called kalium in Latin, and that's why we say hypokalemia and hyperkalemia and normokalemia. So the word, the kalium, and that's the name of this strongly alkaline metal in Latin. And this actually came from Arabic, which is kalawi, kalium. The original word is actually Arabic, by the way, kalawi. And the Latin tried to, to pronounce it or to rename it. They call it kalium. So kalium comes from kalawi, which is alkali. And it's actually, it's obtained from plant ash. And then the English in the 1800s came up with the word potassium. Where did the word potassium come from? There is no relation between potassium and kalium, by the way, linguistically speaking, in terms of language. But potassium, it's the same thing, but potassium in English, where did this come from? It came from potash. What is potash? It's 2 words, it's pot, ash. And what is that? They used to burn wood. They bring woods, they burn them in big pot. And that the ash of that wood after it's burned is called potash, potassium. So this is where all these names came from. By the way, if you add potassium, and I think we all did that in the chemistry classes in the preliminary year in medical school, if you add potassium to water, that gives you potassium hydroxide, and that's one of the strongest burning alkalis, alkaline solution, and that releases hydrogen. And that actually will be attended by a small explosion, the release of hydrogen and the burning and the chemical reaction. So it's a very strong alkali metal, potassium. So this is a case in point. I mean, I modified the case a little bit, but it's fairly typical of what you see in the emergency room when they call you in the middle of the night, a 23-year-old male with insulin-dependent diabetes. He came to the emergency room with vomiting, epigastric pain, cough, and fever. You examine the patient, he's febrile, he's dry, very dry, dehydrated, lethargic, and he has signs of community-acquired pneumonia. His COVID is negative, by the way. I know everybody worries about COVID test. Even if you come with an acute heart attack, they do a COVID test on you. So he's COVID negative. The investigations showed severe hyperglycemia. Blood sugar is like 1,000. And he has acidosis as well as acidemia and ketosis and hyperkalemia. Potassium 6.9. Typical story, typical presentation. He also has leukocytosis and chest X-ray showing left lower lobe lung infiltrate. So this is the case that's presented. Just a little bit, I will talk about this if we're going to give a separate talk on acid-base disorders. You have to differentiate between acidosis and acidemia. And very simply, acidosis is a condition, osis is a condition, and it actually just means a low bicarbonate in your chemistry profile that you run. And then the acidemia, that means the pH is low. Emia, blood, so that means the pH is low. You could have acidosis without acidemia, of course, but that's just, I want to make sure this is clear and everybody understand the difference. So in this case, the diagnosis of diabetic ketoacidosis was made, plus community-acquired pneumonia, and the treatment was started right away, of course. Give a liter or two of normal saline very quickly, wide open, 2 lines, give IV insulin infusion, and start antibiotics right away, ceftriaxone and erythromycin to cover community-acquired pneumonia. So the question is, what of the following do you anticipate to happen in the next couple of hours? You started IV fluid, you started insulin drip, you covered with antibiotics, and now what? This is important because the first thing we want to do in these cases is not to do harm first. We want to treat the patient, of course, but we have to avoid iatrogenesis, and that is that's doctors induced disease. So what do you expect in 2 hours? Hypernatremia, hyponatremia, hypokalemia, or worsening hyperkalemia? Anybody can open their microphone and answer. I think the answer is easy, but I just want to hear it from somebody. Want to make it
hypokalemia.
Hypokalemia. That is correct. Yes, absolutely. Hypokalemia. That's what is expected in the, you really have to pay attention to this and follow that very closely. So during the treatment in the early hours, the electrolyte changes during diabetic ketoacidosis therapy. What causes that hypokalemia during the treatment in the first 2 hours? Is it the normal saline you're giving, the insulin infusion you're giving, or both A and B? Yes? What causes the hypokalemia? I think Dr. Nahla, you answered it correctly. So what do you think has caused it? Why did the potassium drop from 6.9 to 3.2 in 2 hours? And that can happen. That's a big drop. Yes, anybody?
Insulin, B.
Insulin, sure, insulin does it. We'll explain that. I actually have a few slides on how insulin does that. But how about normal saline? If I don't give insulin, if I just give normal saline and insulin is not available, I'm working in a peripheral hospital. Somebody has to go get insulin from the neighboring hospital or from somewhere else. And I just give 2-3 liters of normal saline, I can tell you the potassium will also drop just by giving saline. And I will explain that towards the end of the talk. But the answer is both A and B. They both cause that. Now let me just now talk about the concept of the total body potassium. In a 70 kilogram healthy person, what is the approximately expected total body potassium content? Not concentration, content. Anybody? Let's try. Okay, if I tell you it is 50 milliequivalent per kg. So the answer would be C. It's really important to understand the difference between the concentration in the blood and the total body content of potassium. So how is potassium regulated? How is potassium homeostasis regulated? So this is a physiology part of potassium. As I just said, the content of the total body potassium is 50 milliequivalent per kilogram body weight. So the answer to this question is 3500 C. And of course, the more the body weight, the higher the total body potassium concentration would be. How is that potassium distributed in the body? 98% of this total body potassium is actually inside the cells. It's intracellular. And if you are working in a lab, a big lab, and you're able to use some special kind of pipette to take the cytoplasm out of the cells, you go through the cell membrane and you take a little bit of cytoplasm and you send it to the lab to measure the potassium concentration in the cytosol or the cytoplasm. The concentration will be 150 milliequivalent per liter potassium inside the cells. Only 2% of the total body potassium is actually extracellular outside the cells. And that maintains a potassium concentration between 3.5 and 5.5 milliequivalent per liter in the blood or the serum or the plasma. So that's a distribution of potassium. What maintains this distribution? Why is potassium so concentrated inside the cells? This is the driving force here, we call it. It's called the active sodium potassium ATPase pump. This is a very powerful driving force that maintains the potassium inside the cells at this high concentration. There are other reasons that drive this pump or this force, and that is to balance the electrical voltage across the cell membrane. This is very important. You remember the action potentials from basic physiology, that the negativity inside and the positivity outside. The cause of the electrical negativity in the cytoplasm is actually a lot of anions, we call them, those negatively charged atoms, especially phosphate. And these anions cannot get out of the cell. They just can't, because they are big, big molecules. For example, phosphate, huge, very large macromolecules. They can't cross the cell membrane. They always stay inside the cells, inside the cytoplasm. And so potassium has to make this trip out, in and out, in and out to balance them. They're concentrated inside intracellular to neutralize those negatively charged anions inside the cells. So this is very important. Maintaining this electrical voltage across cell membrane is very, very essential and vital for all organs in the body, including the heart, the muscles, and the liver, and every other organ. So these are the factors that influence potassium moving inside the cells. I talked about the sodium potassium ATPase pump, and then this beta adrenergic, sympathetic beta adrenergic activity moves it inside the cells. Insulin, and you just mentioned that in the answer to the question, insulin also, independent of glucose, moves potassium from outside the cells to the inside. And then also potassium moves down the concentration gradients. If you have a high potassium, 6.9 in that patient, if it's that high there, it moves down that gradient. And of course, alkalinity of the blood moves the potassium inside the cells. Why does it do that? Alkalemia. You know, alkalemia, alkalosis, alkalemia. Why does alkalemia moves potassium from outside the cells to the inside of the cells? Very simple. When there is alkalemia, that means the pH is too high, right? That means hydrogen ion is too low. That's alkalemia. So what happens? Potassium senses these differences, these problems. These are problems. And what does it do? It moves inside the cells in exchange for hydrogen ions that moves outside the cells to correct the acid base. The pH takes priority. When the pH goes up 7.5, 7.6, you know, that takes priority. There are always priorities in physiology. So as soon as there is alkalinity or alkalemia in the blood outside, hydrogen ions has to move out from inside the cell to the outside to lower the pH to normal, 7.40. And if hydrogen ion, that's hydrogen plus, H plus moves outside of the cell, K plus has to move inside in its place to maintain electrical neutrality. So that's the explanation why alkalemia causes the potassium to move in and causes hypokalemia as well. What are the factors that move potassium out of the cells? Alpha adrenergic activity, physical exercise, like running marathons or going to the gym, that moves the potassium out of the cells. Hyperosmolality, or hypertonicity, when the tonicity of this extracellular fluid is high, like you're hyperosmolar, your osmolality is greater than 285 milliosm per kg. So potassium would move out of the cells. What moves it out of the cells here? I get asked this question a lot. What moves potassium outside of the cells? I mean, I just explained why here, when you have alkalemia, it moves in exchange for hydrogen ion, but in hyperosmolality, the mechanism that moves potassium out of the cell is very interesting. It's called the water drag, water drag. So you have high osmolality in the blood. What does the blood need to lower the osmolality? It needs water. Okay, there is not enough water in the extracellular fluid. What happens? The water inside the cells, inside the cytoplasm, have to rush out through the cell membrane to the outside. Under oncotic, osmotic, and oncotic negative pressure, moving it out. And when the water moves out of the cells to the outside of the cells, it drags potassium with it. They call it the water drag of potassium. Just تجر معاه جر كده, dragging. So that's the mechanism of the potassium moving out of the cells in hyperosmolar states. And by the way, if you go to the case I presented, the patient has diabetic ketoacidosis. I told you his sugar is 1,000. He's dehydrated. He doesn't have enough water. He has diabetic ketoacidosis. His sugar is sky high. His osmolality will be high for sure. Okay, his sodium would be high. So that's why his potassium is high, that patient, that's 6.9. That's why it is high, because potassium is being dragged out of the cells to correct that hyperosmolality or hyperosmolar state of the high blood sugar. And then other things that moves potassium outside the cells is just cell breakdown, like rhabdomyolysis. Rhabdomyolysis, a trauma, multiple trauma, road traffic accident, multiple contusions that compresses cells. The cells break down and potassium is released to the outside. Acidemia also moves the potassium outside the cells. Same mechanisms. Acidemia means you have very high concentration of H plus hydrogen ions in the serum outside the cells. That has to go somewhere because the pH takes priority. So what happens is H plus moves in, potassium has to move out in exchange, again, to maintain electrical neutrality or the electricity of the cellular cell membrane. So that's how, what are the factors that moves it out inside the cells and the factors that moves it outside the cell. This is not really academic. This is very important in clinical practice, in everyday patient care. You really have to understand these mechanisms, because when I come to talk about treatments for high potassium or low potassium, all of the things I just mentioned will apply. So you have to understand the physiology, the basic science behind these changes to understand the treatments you're giving. How does the kidney handle potassium? First of all, the urinary potassium excretion varies a lot based on the input of potassium or the total body potassium content. It varies significantly. But generally, most of the filtered potassium in the glomerulus, in the kidney, in the glomerulus of the kidney, most of that filtered potassium is reabsorbed by the tubules and actually secreted distally in the very late distal part of the collecting tubules. Glomerular filtration, how does the glomerular filtrate or the glomerular filtration affect potassium? 15% of the plasma potassium is actually protein bound. So there is no effect. Since it's protein bound, then it's not filtered because of the strong protein binding. 85% is freely filtered. Only 5 to 15% of filtered potassium is excreted. In the proximal tubule, 70 to 80% of the filtered potassium is reabsorbed passively. In the loop of Henle, the second part of the renal tubules, potassium handling differs between the short and the long loop of the nephrons. There's a net reabsorption in the outer cortical nephron, and in the distal tubules, the late region, this is, I just mentioned, this is the major site of potassium secretion into the lumen of the tubules. The collecting duct, active secretion in the cortical segment, but there is passive movement in the medullary segment following the concentration gradient. Other factors that influence kidney potassium handling is the mineralocorticoid hormones. They are potent choliuretic, leading to excretion of potassium, and they also increase the sodium potassium ATPase activity in the distal tubular cells. So steroids, mineralocorticoids, lower potassium both ways. The redistribution on the redistribution side and in the choliuresis side or excretion. They just move it out of the blood. Glucocorticoid hormones, they have a direct tubular effect, stimulate potassium secretion. Acid-base balance, I mentioned metabolic acidosis, suppressing potassium secretions. Metabolic alkalosis enhances secretion in the late distal tubules. This is very important, at tubular flow rate and sodium delivery in the distal nephron. That's why when I asked the question about what brought the potassium down from 6.9 in that case, is it the normal saline, is it the insulin, or is it both? And that here is the answer to that question. Just giving normal saline and increasing sodium delivery, giving a lot of sodium and water, just hydrating the patient will lower the potassium. It stimulates potassium secretions in the lumen of the tubules. And as sodium is delivered is moved, is delivered into the distal nephron, then it get exchanged for potassium. So potassium get more. If you don't have a good tubular flow or sodium delivery in the distal nephrons, you're not going to have adequate potassium secretion or excretion. And then, of course, diuretics. We know all about the furosemide and the thiazide diuretics. I'm not talking about the potassium-sparing diuretics. The extrarenal potassium regulation outside the kidney. Hormones, insulin directly increase cellular uptake by hepatic and muscle cells via the ATPase. You know, when we come to the treatment later of severe hyperkalemia, you know, we all give D50 and insulin. And a lot of people were thinking, because, well, I remember myself when I was a resident, they used to tell us, you know, you give D50 and you give insulin 10 units and 10 cc's or 50 cc's of D50, because then the insulin will move the sugar inside the cells, and then it drags potassium with it. That is not the case. The answer is, that answer is wrong. The actual answer is insulin itself has a direct effect on the ATPase pump, and it moves it independent of glucose, independent of glucose. The only reason you give glucose because you're giving insulin. You don't want the patient to be hypoglycemic. And then the catecholamines, the epinephrine causes a biphasic response. That's up and down. There is an initial hyperkalemia followed by hypokalemia, and the liver and the muscle cell uptake is inhibited by beta blockers, by beta blockade, and enhanced by beta stimulation. So beta blockers generally give you hyperkalemia, and albuterol beta agonist give you lower your potassium. It's actually one of the treatments we use to lower potassium, albuterol or salbutamol or all these things. So beta blockade causes hyperkalemia. Don't forget that. If you have a patient who's running a high potassium and they are on metoprolol or other beta blockers, then remember that fact. You know, beta blocker can cause hyperkalemia. They inhibit the uptake of potassium by the liver cells and by the muscle cells. And then, of course, aldosterone enhances colonic potassium excretion, especially in patients with advanced, I'm sorry to use chronic renal failure here, it should be CKD, advanced CKD. So actually there's an upregulation of these receptors and in the colon, and aldosterone can actually help patients with stage 4 going into stage 5, just pre-dialysis, in actually excreting potassium through the colon into the stool. Osmolality, I mentioned that. This is again extrarenal. Hypertonicity causes hyperkalemia. I explained that. That's the water moving out of the cells, dragging potassium with it. And these are the ratios. Potassium rises 0.4 to 0.8 millimole per liter for every 10 milliosmol per kg increase in the osmolality. It's actually predictable. Exercise, potassium is released from the cells and reuptake enhanced with conditioning. Drugs, lots of medications affect potassium. Digoxin inhibits this pump, the sodium potassium ATPase, and that leads to hyperkalemia. Okay, the situation here is very weird, very strange, because hypokalemia causes digoxin toxicity. And then if you have digoxin toxicity, it causes hyperkalemia. So we have to be aware of this tricky situation between digoxin and potassium. Non-steroidal anti-inflammatory drugs suppress the prostaglandin-stimulated renin-angiotensin-aldosterone axis, leading to high potassium. That's how NSAIDs cause hyperkalemia. The gastrointestinal tract contribute to about 10% of potassium excretion, but in advanced kidney disease, kidney failure, these increase to 80%. You see how the body, how God created the body to adapt to this situation. This is very interesting. So the colon normally, in a normal person with normal kidney function contribute to about 10% of potassium excretion. But if you have advanced kidney failure, that actually gets upregulated and it's increased to 80%. Salivary glands, the stomach itself, the terminal ileum, the colon respond to aldosterone. Hypokalemia is defined as a potassium concentration less than 3.5. Causes, of course, could include inadequate intake, high carbohydrate diet, high alcohol consumption, anorexia nervosa. Transcellular redistribution causes hypokalemia, like metabolic respiratory alkalosis, insulin, mineralocorticoids, sympathomimetics, and familial hypokalemic periodic paralysis. I don't like lists. I can't memorize lists, honestly, but it's very difficult to memorize lists, like what are the causes of atrial fibrillation? There will be like 20 or 15 different causes. But if you understand the mechanism of atrial fibrillation, or in this case here, hypokalemia, I just talked about, if you understand the physiology and how potassium moves and where does it move and what moves it, you don't need to memorize these lists of causes. They're really falling out of favor. If somebody asked me what are the causes of hypokalemia, I would just very quickly try to think about what moves potassium around and what gets potassium out in the late distal tubule. That's, and GI losses. So these are the causes. Don't try to memorize lists. Try to understand mechanisms of disease. Excessive renal losses, diuretics, certain antibiotics, certain chemotherapeutic agent, lithium, mineralocorticoid excess states like Cushing's, primary hyperaldo, licorice, intrinsic renal disease like renal tubular acidosis, and the tubulopathies, other tubulopathies like Barter's. Hypomagnesemia, very important cause, because and we see a lot of hypomagnesemia in our transplant patients, but if you don't correct the hypomagnesemia, no matter how much potassium you give, you're not going to be able to correct it. So if you have a patient in the hospital who's hypokalemia, and you keep giving them 40 milliequivalent KCl, and it's not correcting, check the magnesium. If the magnesium is low, correct it, and then resume correcting the hypokalemia. DKA during treatment, I mentioned that's a case I presented. Leukemia, this is just basically due to too many numerous hundreds of thousands or millions of white blood leukemic cells, and they consume potassium. There are just too many cells. And hypercalcemia also can lead to hypokalemia. Tubular effect, by the way. This is not a redistribution effect. Excessive GI losses, even vomiting and diarrhea can cause it, especially villous adenoma of the colon. It actually secretes very high potassium in the diarrhea stool in patient with villous adenoma. Laxative abuse, these are the cases you get in your board exams. A young female who's trying to lose weight, abusing diuretics or abusing laxatives. There's always hypokalemia there in the mix. So whether they're abusing diuretics or laxatives. And excessive skin losses, like in Riyadh in July and August in the heat, and excessive sweating, that can also lead to excessive potassium loss. What's the diagnostic approach to the hypokalemia? Redistribution first. And it's very simple. I personally just measure a spot urine, just a little sample of urine for potassium. If the concentration of potassium in that spot urine is less than 20, then the kidney is doing its job. The patient has hypokalemia, systemic hypokalemia. If the concentration of potassium in that one little urine you send to the lab is under 20 milliequivalent per liter, what does this tell you? It tells you that the kidney is doing its job. The kidney is conserving potassium and it's not losing potassium. There's no potassium wasting. And so the loss of potassium must be extrarenal wasting. That's when the urine potassium is low. If you have systemic hypokalemia, let's say potassium 3.5 1 or 3.0, and you still have a spot urine potassium greater than 20 milliequivalent per liter, then this is renal wasting. This is renal wasting of potassium. The problem is in the kidney. So it's very easy, very simple, and very easy to figure out whether the problem is the kidney or not kidney, because we are nephrologists, by the way. So we're nephrologists. We want to know if the problem is the kidney or something else, like GI or anything else. What are the consequences? Cardiac, cardiac, cardiac first, cardiac effect. And again, just like I'm going to do with the hyperkalemia part, this is the events, the sequence of events. The first thing you're going to see is you see a flat T wave. And a flat T wave, if it's followed by a prominent U wave, which normally is not prominent, people even don't pay, then this is really getting severe hypokalemia. So the first sign is a flat T wave followed by a prominent U wave. And at this point, after that, if you don't do anything, there is a very high risk of ventricular arrhythmia, especially true in patients who has ischemic heart disease or even left ventricular hypertrophy, especially true in patients who are on digoxin. I mentioned this earlier. I said hypokalemia causes digoxin toxicity, causes arrhythmia, serious ventricular arrhythmia in the presence of, in the patient who was digitalized. It causes skeletal muscle weakness, and it reduces smooth muscle motility, and that manifests clinically constipation, ostipation, ileus, even functional obstruction. Severe ileus can happen. It also causes an atonic bladder because it reduces the smooth muscle motility and contractility, so the patient can actually develop urine retention as a result of hypokalemia. Hypokalemia causes rhabdomyolysis, and when rhabdomyolysis happens, cells die, they break down, and when they die and break down, then they raise your potassium. Okay, just similar to the story with potassium and digoxin. You see, so rhabdomyolysis, hypokalemia itself causes rhabdomyolysis. Why? Because of its effect on the muscles, the integrity of the muscles. They just cells and muscles break down, and that can ultimately lead to hyperkalemia. It also, hypokalemia causes impaired urinary concentration, and this can manifest as nephrogenic diabetes insipidus. How do we treat it? Beware of, you have to understand, again, back to physiology, you have to understand the poor correlation between total body potassium content and serum potassium concentration. What do I mean by that? You could have hypokalemia, but the total body potassium will be high. Okay, like for example, patient who's been taking potassium, they come in with hypokalemia for redistribution problem or any other problem, but don't forget their total body potassium is high because the cardiologist have been giving them potassium, or the primary care physician has been giving them potassium for several months. So they could have, you could have high total body potassium and low serum concentration of potassium. There is no correlation between the two. If you want to give intravenous potassium, this should only be given for severe hypokalemia with symptoms or with cardiac effect, as I just explained in the ECG, you know, the flat T's, the prominent U's, or widening QRSs, whatever, all this cardiac effect, you have to give corrected IV. Otherwise, I prefer oral potassium. If you want to give IV potassium and you want to give more than 10 milliequivalent per hour, the patient has to be in a monitored setting, cardiac monitored setting, not in a regular flow. If you're giving more than 10 milliequivalent per hour, rate the rate, okay? Don't put them on the floor and tell the nurse to give them, you know, 20 milliequivalent an hour because their potassium is too low. They have to be monitored. And then, of course, you have to correct the underlying problem as you're treating it, hand in hand. Now we're going to shift gears to hyperkalemia. Could be factitious. That's like pseudo. That's not real. It's a problem in the lab usually. in vitro problem, not in vivo. Actually, in vivo, in the body, in the patient body, they might not be hyperkalemia, but the cells are breaking down, hemolysis, the platelets are extremely high, like millions, or the platelets usually, of course, they have to clot the specimen to measure the potassium in the serum. And when the platelets are clotting, they are releasing potassium. So this is not true. Repeat the potassium. Even sometimes, even just a difficult venipuncture, if the nurse is trying to draw blood and she struggles and she sticks many veins, that can cause hyperkalemia, by the way. If the specimen is left on the floor or in the emergency room for a long time, that can give you hyperkalemia. Acidemia, I think I explained that, the relation between H plus and K plus, acidemia, high concentration of hydrogen ions, that has to move inside the cells because the pH has to be corrected, but then potassium has to replace it. So potassium comes out of the cells. Increased input, either exogenous diet, the highest diets that have potassium, the highest potassium content diet is avocado, bananas, and orange, I think. In the US, patients with hypertension, several years ago, they were marketing something called salt substitute. It's still available here in Riyadh in the GNC stores and the general nutrition stores. What is salt substitute? It's actually potassium chloride instead of sodium chloride. And they use that for their cooking. They use it as a substitute for table salt. Table salt is sodium chloride, but the patient would have hypertension or congestive heart failure or liver cirrhosis. So the potassium, this is pure potassium salt. This is like somebody who prescribed 40 milliequivalent of KCl daily. Several other medications, endogenous causes like GI bleeding, hemolysis, of course, hypercatabolic state, and any other state associated with tissue breakdown. Inadequate causes of hyperkalemia still, inadequate distal delivery of sodium and decreased distal tubular flow. I talked about that. Adequate amount of sodium and water has to get to the distal tubules for potassium to be exchanged there, to be secreted into the lumen and get out of the body in the urine. But if you don't have enough sodium and water delivered to the distal nephron, you're not going to have sodium moving out of the lumen into the blood and potassium moving out from the blood into the lumen of the tubules and out in the urine. So you're going to have hyperkalemia. Did I miss a slide here? Yeah, I think we're good. Okay, so yeah, renal failure, of course, we're aware of that. In a chronic CKD, especially when the GFR is less than 15 ml a minute, it's a big problem then. Impaired renin-angiotensin-aldosterone axis, Addison disease, a lot of medications, including heparin, which blocks the aldosterone system. It's an anti-aldosterone. Beta blockers. Also, I talked about that. NSAID, I talked about that. ACE inhibitors and ARB and DRI. I don't think I need to talk about that. We talked about them enough. Primary renal tubular secretory defect, as in sickle cell disease, lupus, and the post-transplant patients. They have some primary tubular defects, especially if they are on tacrolimus, which in itself causes hyperkalemia. There are some differences I'm really interested in between a transplant kidney and a native kidney. We know the transplant kidney is a denervated organ. They don't transplant the nerves. And so the neurohormonal axis of the transplant kidney is a little disabled, if I may say. And then obstructive nephropathy also causes hyperkalemia. inhibition of tubular secretion, spironolactone, the potassium-sparing diuretics, the ameliorides, the triamtrins, and of course the Gitalus, as I mentioned. Abnormal distribution, acidosis, I talked about, insulin deficiency, hypertonicity due to hyperglycemia or any other cause, aldosterone deficiency, beta blockade, periodic paralysis, tissue damage, and digitalis. What are the consequences of hyperkalemia? Cardiac, cardiac, cardiac. I think I showed these numbers. I don't know where I got these numbers from to correlate with the ECG changes, but I think it's just from my personal observations over the years. A peak tall T waves suggest a potassium of 5 to 6, and then followed by flat or absent P waves, and that's usually when the potassium is 6 to 7, and then that's followed by the widening QRSs. And don't leave the patient with widening QRS complexes, because the next thing you see is going to be cardiac arrest. And this usually happens between a potassium of 7 to 8, sine waves, 8 to 9, and then ventricular fibrillation, cardiac arrest. It also causes skeletal muscle weakness, and it impairs the urine acidification. It impairs urinary acidification as well. This is the widening QRS going into the sine waves, and this is how you treat it. The first thing you want to do is stabilize the myocardium with 10 ml of 10% IV calcium gluconate or calcium chloride, doesn't matter. This basically stabilizes the myocardium without changing the potassium concentration. It does not lower the potassium concentration. It works within minutes, 2 minutes, but it buys you time only for 60 minutes. You only have an hour to do something, because if you don't do something after 1 hour, you know, you're going to have the cardiac complications again. You could give sodium bicarbonate to induce alkalemia, which moves potassium intracellularly. It increases potassium excretion by the kidney. Sodium bicarbonate, increase sodium, increase water, increase distal delivery of sodium and water. Then what happens? The sodium in the lumen of the distal tubules moves into the blood, in the peritubular capillaries, and potassium from the blood in the peritubular capillaries moves inside the lumen of the distal tubules and gets out of the body. So that's how you increase the potassium secretion or excretion by the kidney, increasing the distal sodium delivery. Very important mechanism. This question is very common in the American boards, both internal medicine and nephrology. Every year they have this question. Insulin and glucose, I talked about that. It stimulates, insulin directly stimulates potassium uptake by the cells. People give 10 to 20 units of regular insulin with 50-gram glucose over 1 hour. I want to say something quick here. I think we still have time, yes. You know, be careful if you're giving D50 and insulin, please. Be very careful, because I have seen cases over the years where people give the 50-gram glucose, okay? And then they want to give another 50. This is a very viscous, very thick solution you're giving. I think they better give it in a bag of normal saline or something. Because if you're giving 50 grams of glucose and you didn't give the insulin yet, and I explained the role of glucose here, the role of glucose is really to combat hypoglycemia from the insulin. But if you're giving 50 grams of glucose, you're going to raise the osmolality. And if the potassium is already 7.5 or 6.9, like in this case, and you raise the osmolality, what's going to happen? Water will move from inside the cells, drag potassium with it to the outside, and then boom, potassium will be 8 or 9, have cardiac arrest, you know? So that's why I personally suggest giving the insulin first. Give the insulin first, because independent of this glucose, it stimulates the potassium uptake. It stimulates the sodium potassium ATPase pump, moves it inside the cells. Then you give the glucose to, so this is really important. I've seen a couple of cases where that happened. The osmolality just went up and then they crashed with cardiac arrest. Cation exchange resins, This is the name they use in the US, Kxalate, but they have different names in different places. And it can be given orally through a nasogastric tube or rectally. You can give 15 to 60 grams. I think there is calcium resin in the hospital here. So 15 to 60 grams in 70% sorbitol to induce a diarrhea. You have to get diarrhea. You have to get 2-3 loose bowel movement. Otherwise, it didn't work. This cation exchange resins. If the patient did not have diarrhea or a good bowel movement, give them another dose of sorbitol or lactulose or something. Diuretics, loop diuretics are preferred. Those according to the GFR, of course. And then, of course, dialysis is always available. Hemodialysis, of course. I don't think you're going to use peritoneal dialysis to control hyperkalemia. Now, there are patients with stage 4 CKD who have chronic hyperkalemia. Potassium is always around 6, 5.9, 6. Advise them about dietary intake. Don't advise the salt substitute. These are potassium chlorides. Low potassium diet, this is a recommended amount. Avoid drugs that predispose to hyperkalemia. Avoid volume contractions. Liberalize sodium intake to improve the distal delivery. Sodium bicarbonate, you can give sodium bicarbonate tablet or the calcium, the cation exchange resins to induce GI losses of potassium. That's all, I think. If anybody has any question or comments, please feel free.
Thank you, Doctor. Thank you very much for this presentation. It was very helpful. I have a simple question. Regarding management of hyperkalemia with insulin, the 50-50. It is the fastest action. Does that mean the duration of the correction only will last 30 minutes, and after that, this effect, the potassium will increase as it was before giving the insulin, or no?
Yes, it's a redistribution. Remember something, the cause of the hyperkalemia probably is still there, and you're really buying time. It's a you're redistributing the potassium from the extracellular fluid, from the plasma, you're pushing it inside the cell. That's all what you're doing. But if you don't do a definitive treatment, and of all these options I mentioned about treatment, the only two options that really move potassium out of the body is dialysis, of course, dialysis, maybe diuretics, and the cation exchange resins. The other modalities of treatment, like calcium gluconate, that's basically just stabilizing the myocardium, buying you time, buying you 1 hour, 60 minutes only, you have to do something. Even sodium bicarbonate might help with the excretion, but in the immediate period, you're inducing alkalemia or alkalosis, and that will also move potassium intracellularly. So here, sodium bicarbonate, basically, you're using both. You're using both modalities to lower potassium. Number one, you're moving it, you're shifting it, redistributing it intracellularly, but also it increases potassium excretion by the kidney. So ultimately, it does help, okay? And now the other modalities, this one here, basically, I agree with you. It's basically just moving. So it's a temporizing measure. It buys you time, stabilize the patient, and you got to figure out how you're going to remove potassium out of the body with this modality or with this modality. I mean, the dialysis. So these are the only two modalities that probably effectively remove potassium from the body if the patient is total body potassium overloaded. You agree, Mamoon? Mamoon is with us?
Yes, yeah, I do agree. Thank you, Bakri, for really tackling a very difficult subject of electrolyte imbalances. It's always a difficult, one of the difficult aspects of renal care. Just have a couple of comments. So, as Dr. Bakri said, most of these measures is to redistribute the potassium, but it's still there. The total body potassium is still high despite the serum concentration has become low. So the dialysis, the diuretics, if you have a urine output, and the cation exchanges. Just want to add that similarly for the hyperkalemia, you can use nebulized salpetamol,
Yeah,
which it does exactly the same thing as insulin do.
absolutely.
So yeah, so but the main thing is I noted here people are a bit usually in really small doses, 2.5 milligram or 5 milligram. Although all the trials I looked at regarding treating hyperkalemia, salpetamol has used the 10 milligram nebulized salpetamol. I think that is something we need to put in mind. I know the patient will be a bit tachycardic, but the effective dose is 10 milligram to me. And I've seen people giving 12.5 milligram and nothing happens. The other thing is regarding cation exchange. Now we have newer newer lads and boys in the block. We have which have lesser side effects than the calcium, resonium, and the catalase. We have Patimer. I think this will come to the hospital soon. It is marketed commercially as Baltaza. So it has a lot of advantages, especially in chronic hyperkalemia. Patients who are having congestive heart failure and need ACE and ARB to improve their cardiac function. It is calcium based, so that is a bonus. The other one is the sodium zirconium silicate. It's more or less the same, probably acts a bit more quicker than the Patimer, but the drawback is that it is sodium based. I think that will be just comments in addition to the management of hyperkalemia in our patients. It's a major problem really in patients with chronic kidney disease and having cardiac abnormalities, congestive cardiac failure. And if you want to improve the left ventricular function, heart function in general, the always hyperkalemia from the ACE and ARBs and the spironolactone has been a limiting factor in maximizing the care of these kind of patients. And mostly these patients will need diuretics, will need calcium resin exchanges. And ultimately, sometimes they may need dialysis. And I think that is something sometimes we think of. And we always try to reduce the ACE and ARBs, but I think currently now with this new calcium, the cation resin exchanges, I think things will be better. But really, Dr. ElTayeb, thanks for really delivering an elegant lecture regarding a very difficult topic of potassium electrolyte and general electrolyte abnormality has always been, as you know, in fellowship and in renal subspecialty is a difficult part, probably one of the most difficult areas to tackle in nephrology. Thank you.
Great, thanks so much. Thank you for adding that albuterol nebulizer. Very easy, very quick, really works very well, beta agonist. And it's, again, also in the terms of the modalities we mentioned, it basically, it moves potassium inside the cells. It does not remove it out of the body also. Any other questions or comments? Thank you, Mamoon.
Thank you so much, Dr. ElTayeb, for this amazing lecture. I just have two questions. The first question is, what is the recommended sodium bicarb dose in hyperkalemia? And the other question is more of local. Here, doctor, in the medical field, we encounter patients with hyperkalemia a lot. And unfortunately, the hospital doesn't provide calcium resonium anymore. It's been out of stock in like 6 to 8 months. So do we have in our hospital another drug that can we use in the GI elimination of potassium?
Yeah, good questions. So first about how much bicarbonate you're giving. It's very important, first of all, that you don't want to precipitate hyperkalemia. You want to induce relative degree of hyper alkalosis. You want to induce a relative degree of alkalosis so you can get the hydrogen ions moved out of the cells and the potassium to move in, but do not induce hyperkalemia. How much? I would say 150 milliequivalents would be enough if the patient is not already on the hypokalemic side. if you're not volume contracted, because contraction itself causes alkalosis, of course, you can get contraction alkalosis. In terms of the resins, I think Mamoon just mentioned the latest on these. But, you know, I would give sorbitol. I used sorbitol before. There are situations where it's not, the resin itself is not available. Basically, the idea is I want to induce, of course, there is it's an exchange resin. Like there is a benefit to inducing a diarrhea. You want to induce some degree of diarrhea. That may help too. But Mamoon, would you do you have anything? I think it's very important to get these resins available. Do you have any idea? I think you.
Yeah, I think the Patmore has been approved by the Saudi FDA, and I think the hospital drug committee will approve this soon. I think we should be available soon in the hospital formulary. And I think it's going to be a great help to the nephrologist and the cardiologist and probably the diabetologists who are using a lot of ACE and ARBs. And the maximum benefit of ACE and ARBs and spironolactone being always limited by hyperkalemia. As I said, most of the time we stop or reduce the dose, and that is definitely affect the efficiency of the medication and jeopardize the care of these patients. Congestive heart failure will continue because the maximum ACE and ARBs, the blockade of the RAS system is not achieved. So I think Baltazar Patmore is slightly long acting more than the sodium zirconium silicate. I don't think sodium zirconium silicate is available in the Middle East yet. Witnessed that when I was back in the UK. Patmore has already been used in North America and in Europe, and it is available now in Saudi Arabia. I think it should be in the House of Formulary soon. We spoke about this recently, and I think hopefully in a very short time will be available for use. We're just preparing the case for that to make sure that these resin exchanges can be approved. The Baltimore, the Baltazar will be available. I think sodium zirconium silicate will take a bit of time as another alternative to use. Probably because of the sodium content, may not be quite useful for patients who have congestive cardiac failure and salt overloaded. But for those who have not, it is quicker than the Baltimore, and the mode of action is more or less the same, but the action is quicker, only as quick as sometimes giving Ventolin and insulin, maybe, but is not approved for acute treatment. These are for chronic usage.
Yeah. Okay, good. I just want to say one thing. I was expecting somebody to ask me, but what is my comfort level for hyperkalemia in our renal patients? 5.6. That's just from my life experience. Up to 5.6. If I have, Mamoon just mentioned that if I have to keep the patient on ACE inhibitors or ARB, or of course in our transplantation tacrolimus, which causes hyperkalemia, I am comfortable with a potassium of 5.6. So I don't jump on the patient, stopping medications or even giving them aggressive treatment for a potassium up to 5.6. And that's the comfort level for most nephrologists. Would you agree, Mamoon, with 5.6 or?
Yeah, I'm glad you mentioned that. And we know that the cardiac effect of the hyperkalemia is actually dependent on the rate of change in potassium. Yep. So if you have chronic potassium, some patient with a potassium, let's say, as you said, 5.6 for quite a long time, and then it's slowly risen to around 6.5. It is really very unlikely to have any cardiac deleterious effect.
Yeah,
but if you have someone with a potassium of 3.5 and then all of a sudden it's risen to around 5.5, that's the kind of patient you actually be worried about. So irrespective of the potassium level, the shift in potassium level is actually what destabilizes the cardiac myocardial myocyte, destabilize the myocyte, the membrane. So it is the rate of change. That's why chronic hyperkalemic patients don't get a cardiac ill effect of hyperkalemia unless really the shift is big. So 5.6, 5.5 is a comfort zone. If it has been chronic like that, I won't be worried. Right? If it obviously the shift from 5.5 to 7.5, that makes you worry. Equally important if it is 3.5 all the time, and then all of a sudden it becomes a 5.5, then 5.5 itself may be a problem because of the big shift between 3.5 to 5.5.
Exactly, right, correct. So I remember when I was a fellow and a resident, when they call us from the emergency room, hey, this is a dialysis patient, you know, Amun, your patient that come crashing in the emergency room. Oh, this is a dialysis patient and they didn't go to dialysis last night and now they're here with a potassium of 6. I said, okay, call me when it is 8 or 9 or something.
Exactly. So there is not a big shift because it's always been there and thereabout, you know.
Yeah, exactly.
Yeah, it has always been around.
I'm not telling our resident to ignore a potassium of 6.
No, definitely not. No, it is the shift. Yeah, so as dialysis patient, they always is.
They live there.
They live there at around 5.6, 5.7. So I think most of the guidelines, you want the pre-dialysis, they would accept the pre-dialysis potassium up to 6. Some of the guidelines. Although here our guideline will accept a pre-dialysis potassium around 5.6, but some guidelines even a pre-dialysis of 6, especially if the patient has chronic hyperkalemic, really is not worrisome unless there is a big shift, as I said, and that's why the only just the dietary advice will probably suffice.
Great. Thank you. So anybody has
Yes, Doctor, one last question, if you allow me.
Sure.
In our hospital, and there is many references that are conflicting between the upper normal limit of potassium of 5.5, 5.2 to 5.5. You mentioned regarding renal patients, it's okay to limit the potassium limit to be raised until like 5.5. You'll be fine. But regarding patients with who are non-renal or having just AKI or previously like they didn't have any big hyperkalemia, is it healthy to act in 5.2 or to give them a space to 5.5? Thank you, Doctor.
Yeah. So if the patient has an AKI and like Dr. Mamoun said, their systems and their myocardium is not used to a high potassium, absolutely, especially if the patient has been running a low potassium earlier, like a couple of days ago, and then all of a sudden they're up to 5.4 or 5. I would worry about that because that's a rapid change, especially if they are cardiac patients. But I'm talking, when I say 5.6, I'm talking about my patients I've been following for several years, and they have CKD. And I want to keep them on ACE inhibitors and ARB because the benefit of these drugs is just amazing. Even in advanced stages, even in stage 5, you know, they can delay patients from needing to start dialysis. And any day in life without dialysis is a good day. So in these patients, I would accept a 5.6. But if somebody with AKI and they did not have previous hyperkalemia, they're not renal, I mean, they didn't have CKD, I wouldn't worry about that. In my transplantation population, of course, I know they are on FK, and FK causes hyperkalemia for sure. So I would accept it, even if their potassium, if their creatinine is normal, because I want them to be on FK. I just make sure that they're not toxic. The FK level is not toxic, is not too high. And if it is high, I lower the dose and I don't have to aggressively treat their hyperkalemia. Okay. All right. I think anybody else had any question?